Okay, we're live, we're back. This is Senate Health and Welfare, continuing our work on January 25th. And Senator Weeks, you have some, just some information to share with us about gubernatorial appointments. So why don't you go
Thank
ahead?
you. So we have a package of 33 nominations, which range back,
Divided by 5.
which range back to April of last year. And some of them are as recent as November. So we need to catch up. Do you have the single slide? If you could put that up, that would, I think, kind of frame this for everybody. We can gain some traction quickly. There are, these nominations include the Green Mountain Care Board, of which there's 3. One who's the chairman. The Board of Health, of which there's 3. One who's the chair. The Board of Medical Practice, of which there's 7. Human Services Board, of which there's 1. And the Children and Family Council Prevention Programs, of which there's 9. Again, this is new to me, but the chair did give me an outline of how this process may unfold. And that would include for secretaries, commissioners, deputy commissioners, and Green Mountain Care Board members that we would interview, I think, in person, and they would come in here. Okay. So I see obviously the Green Mountain Care Board members, but I don't see others that fit that criteria.
I think you're right. We haven't interviewed any of the others in person. So it would just be those 3 that we have.
So
2 are new and 1 is reappointment.
And so with your permission, what I'd like to do is work with Alex on scheduling. Contact these 3 folks for the Green Mountain Care Board and schedule this.
Yeah, we'll do that. What we'll do is, why don't we do that during our agenda planning meeting?
Right,
We can
right.
start, yeah, that'll be perfect. So now that you know, and then Alex can invite.
Okay, good.
We'll just set some, I'm wondering, didn't we last year do some of this on Fridays? Or we had our discussion about appointments on Fridays, but I think the interviews can be any day of the week. Probably not Tuesday, because Tuesday gets crunched with floor time.
So then the others, I put the hometowns purposely on this list so folks could see, where these people hail from. And then the idea now would be once we
Divvy it up.
divvy it up,
Yeah.
and if you want, if you know a person, that's great. If not, we just kind of randomly assign and get contact information and call.
So did you get this, Alex has this, is this up on our webpage?
Yes and yes.
Okay, so why don't we set a timeline to look at the list and then come back to it, maybe next Friday.
Okay.
How's that work?
This coming Friday or a week from?
A week from,
Okay, very good. Yeah, all good.
yeah,
I think it was just introduce the concept, something we've got on our plate, and then move forward.
it is something we have on our plate.
Might be easier than that. If you might assign us some, only one of those people seem to be in my district.
So how about?
Well, I know, well, you may know some of these people. For example, I know some that are not in my district.
Oh, yeah, I see what you mean.
So just check off the ones that you know. And then, for example, I can do number 6 on the Board of Medical Practice. I can do a number of those.
Okay.
Number 2 there.
All right, so you just want to talk about it again next Friday?
Yeah.
Yeah,
Can I recommend one thing? That if
absolutely.
you have if there's a person on this list who you know personally, just let me know, and then
Okay.
we'll earmark that for you, and then we'll divvy up the rest.
My brain will forget to come back to this. So.
Well, you can always
That's
one-
why I'm like, just tell me what you want me to do.
The Human Services Board only has 1 member?
No, it's just one new appointment.
Oh, okay.
Okay, so
Yeah.
Human
Oh,
Services
okay.
Board has a long list, but yeah. And I don't know what the terms are for some of these, but and that probably not.
How about this, so that you don't forget, I'll just give you the list, and you annotate it,
Thank you.
and then we'll rotate around
Oh, yeah, send it around. Let's do that right now. Let's send it
Okay.
around, then next week.
Then we can move on.
Yeah, good idea.
So we just put our names next to people that okay.
Sorry, I missed this, and maybe I'm not a bit paying attention. What do we
Okay,
do with these folks? Do we call them or talk to them?
yes.
Yeah, that's the next step.
And then so we call, it's essentially an interview, it's a review of their background, and then the committee reports back to the full Senate with the yay or nay on the 33 nominations.
Okay.
And then we feedback to the governor's office that once the Senate has confirmed. And beyond that,
That's it.
I lose the trail.
That's it. Once it's confirmed, it's over. It's our job to confirm their appointment that the governor has made.
Will we have access to their CVs?
So this is the other thing. We've always had a problem getting significant information about some of these folks. What we're gonna ask Alex to do is to connect with the governor's office and get a telephone number or an email or both for each of the people. If there's any other, if there's a resume or something, that'd be great too. Whatever we can get.
And then will you have some questions prefab for us to use? Or is it just more of a conversation?
Well, if, I think the first question is, you're a current member or are you new? If you're a current member, do you want to continue and how do you see your role?
Yeah.
That's all you need.
Oh, okay.
I also just, I asked them a lot of, it's like a sort of mini job interview, because it's sort of our due diligence as the Senate to make sure. I also always Google them, because you never know what you might find. And then
Yeah.
also understand, I learned a lot, like, for example, I didn't even know what the Human Services Board did. And last year I interviewed a couple of people, so like also look at what they're being appointed to and how their appointment works and who are the other people, and ask them about their work on the Human Services Board or whatever it is and how they do that. It's actually a really good opportunity to learn about some of these more obscure boards that do really important work.
Yeah,
Yeah.
good.
Well, the Human Services Board in particular, I'm glad you brought that one
Yeah.
up, because it takes appeals from people who have been denied services.
Ah,
So
Yeah.
that one is really,
very important, yeah.
can be very important.
Yeah, it was
For
fascinating.
medical practice,
Yeah.
similarly.
And then, thank you. Yeah, I'm looking forward to this now. Thanks. We can't discuss these folks in committee, can we? I mean, that's like
We will
discussing
not.
personnel. Yeah, okay.
We will have an opportunity, let's save that conversation, we'll talk about that next week.
Okay.
When we look at that.
Usually you do a little report to the committee
Okay,
in public. No.
Yeah, let's talk about that next week.
okay,
That'll be good.
gotcha.
Thank you, good work. Okay. So Ruth is gonna pass that around, she's gonna select 15 or 30 of those.
How many of them are there total?
33.
33. So
Yeah, your share is 24.
And then we take the Green Mountain Care Board off of there, right? So we're not gonna,
They don't count.
okay,
Because we'll all interview them.
then I'll just pick 6 of them.
Sure.
Okay.
You may not get all the ones you want.
Okay, well, I mean, I don't actually really know that many of them, so I just.
Okay, good. All right, so thank you very much, Senator Weeks, that's helpful. And then we'll talk about how we'll proceed next week a little bit. And Alex, if you can try and get the resumes or whatever information, contact information. I will just say up front, it's not always easy to get in touch with folks. But it can be challenging. Okay, so we have, do you want to go through the list?
I did. It's market.
I don't have anybody.
Okay. Very good.
I know.
Yeah, I just picked people.
Oh, okay.
Yeah.
Okay.
It's-
People
and if they're
nearby.
your constituents, you two should
Okay.
make
Yeah,
sure.
we'll arm us.
So Kathy, why don't you come up? We're almost on time.
So.
So Kathy is part of a program that, she's executive director of a program that you may or may not be familiar with. And so I thought it would be helpful to understand what you do and then how it fits into the broader scheme of healthcare. And so before you begin, we'll go around, introduce ourselves, and then have you introduce yourself for the record and talk about VPQHC.
Hi, I'm Martina Rock-Malik, and I live in Burlington, and I am Senator for Chittenden Central, one of three. Nice to meet you.
Good morning, Dave Weeks, representing Rutland County, and I live in Brock.
Nice meeting you.
Jenny Lyons.
Terry Williams for Rutland District, and I live in Palmer.
Nice meeting you.
Ruth Hardy, I represent the Addison District.
Nice meeting you.
Nice to meet you.
Okay, so why don't you introduce yourself for the record and then tell us a little bit about VPQHC? And I think you're going to share your screen. I mean, you're going to put something up.
Is it showing yet? If I'm getting a message, the meeting host will let you in soon.
Oh, I see you now, yeah.
Wow, you're magic. You're virtual and in person.
For me, we have yet to see the magic.
Okay.
Don't connect to audio.
Now, don't,
No.
yeah,
Exit out
okay,
of that.
just close that. Just want, I just want to continue.
You should now have the ability to screen share.
Okay. And is the title slide up?
Yes, it
Oh,
is.
there we go. Wonderful. Thank you. Okay, I always hold my breath during that process. For the record, good morning. Kathy Fulton, Executive Director of the Vermont Program for Quality in Healthcare. Very happy to be joining you in person today to provide this overview to all of you. I would encourage, if you have questions as I'm presenting, don't hesitate to sing out. Always happy to accommodate the need to understand. And if I fall into acronyms and lingo, just wave a hand or give me the stink eye. So, and I'll correct. So VPQHC, there we go. We are a small, not-for-profit 501c3 established back in 1988 and through a Robert Wood Johnson grant. In 1994, the Vermont legislature established the 9416 Quality Assurance Statute, which also provided build back funding to support our core operations and administration.
And what would be helpful is to define build back funding from whom or what.
So our contributors to that build back funding are the hospitals at 35% of the tab of the build back. The insurer groups pay the remaining portion, making up the other 65%. We work with them very closely in establishing the project work that is part of the contract. But that quality assurance contract establishes VPQHC as the statewide quality assurance organization. And what that means is through peer review and confidentiality protections, we can have very, I would maybe say, difficult and in-depth conversations surrounding improvement. Whether it's misadventures or dissemination of best practice, understanding the gaps in current state, what current performance is, and what best practice can be doing gap analysis and then supporting improvement activities. So those funding initiatives help us, with core administration. Our mission is to improve the healthcare quality in Vermont by studying the system and making it better. We work with many partners to achieve that. Green Mountain Care Board, Department of Health, now Department of Mental Health is another contract. We also work with the Department of Corrections. We'll get into a little more of those details. We have a board of directors that's comprised of healthcare providers representing hospitals and systems as well, insurers, an employer, consumers, and 2 government positions by statute. The Commissioner of Health or designee is mandated member of our board of directors, as well as a second government seat, and then 3 at-large positions. And we work very closely, obviously, with our board. Just jump, there we go. This is our staff. That's the whole staff. I call them the dream team. We have an incredible mix of talent and expertise. We have 2 nurses, a social worker, master of public health. 3 of us are certified professionals in healthcare quality. And that blend of skill really gives us very good strength in supporting the hospitals and our contract partners in implementing improvement activities. This is what the quality assurance contract includes at its core. Peer review is something that we provide as a service to the small hospitals, being able to connect providers. A small hospital with 2 cardiologists can't have the partner reviewing a case of their colleague and friend in that work situation. So we're able to make those connections to a broader list of potential reviewers. We've also recently undertaken a review of our current processes to understand what improvements there are in terms of systems that can support peer review. And we're looking at some of the best practices from other states around the country to apply improvement practice to our own work. And that's been, we've found some very interesting potential new developments that we may be pursuing, and potential expansion to include bi-state and other private practices. Confidentiality, as I mentioned before, those protected discussions. Without the benefit of confidentiality, improvement discussions can be chilled or stop altogether. And that, being able to move to better outcomes and understanding variation in performance is how we develop and evolve to better outcomes and better care and services. We support the quality directors in all the hospitals and the care transition leaders with quarterly network meetings. We bring in subject matter experts, have professional discussions, and those groups work very well together to share resources. Each group has a password protected portal on our website. They can share documents, policies, forms, and they give very willingly to one another. If there's an issue, an email goes out, does anyone have a policy on, for a while, one-to-one supervision in the hospital setting was an issue. Oh, I have a policy, I'll post it in the poll, it'll just change the logo, it's all yours. So that kind of sharing really helps, and no one has to go back and reinvent the wheel. And we're very happy to facilitate those connections. We're also following telehealth and healthcare quality related to telehealth. We have several projects underway. I'll get into those details, but we're also conducting data analysis on the uptake and use of telehealth through the public health emergency, and with very specific interest in emerging best practice from those years and what lessons learned can we gravitate towards and leverage, especially here in Vermont. We also have a tracking tool on some of the legislative changes and updates that we can share with our stakeholder partners so everyone can stay on board. That was one of the features of the telehealth office hours series that we conducted during the public health emergency. You know, billing and reimbursement policies, both at federal and state levels, where those differences were, just to keep everyone informed and have a go-to spot to get that information. We also provide technical support to the National Health Safety Network and the hospital submission of infection protocols, surveillance, just helping to get that information entered into the system, and then we conduct a validation exercise to make sure that once it's in there, it's being picked up by the NHSN and all those results are valid and accurate for all of our hospitals. So we continue to do that. And then our last big bucket under the 9416 quality assurance contract is called technical assistance. And that is huge. And it's kind of, just the big bucket of everything else. When the phone rings, we answer the phone, follow up, run down information, policies, practices. And over these last few years, technical assistance has grown both in its volume and complexity. So that's an area that gets a lot of our attention, and sometimes projects will start from a simple phone call or inquiry, or I'm having a problem with XYZ topic. And then that can actually grow, and if it's a large enough or consistent across several of the hospitals, we'll pursue funding and continue that work with supported outside of the 9416 contract. So any questions?
I have a few quick questions.
Certainly.
The first is, so do you have a staff of tech folks that work for you?
We have an information systems manager,
Okay.
and he handles our cybersecurity policies, keeps us up and running. He made sure I was going to be able to connect to the wireless before I left the building. And we're small, so we're manageable, but we also have a contract with SimQuest for the big things, and he's our connection to SimQuest.
Awesome. And then my other question was, do you have a background in medicine, or did you come to this from an administrative angle, or?
So I've done healthcare quality for a long time. I have to think back, probably over 30 years. Yeah. So I've been around. I was, when BPQHC was in its infancy, I was struggling in local hospitals in New York State to, everything was manual, Excel spreadsheets for everything, manual chart pools, and so it's been I've been able to see the industry grow and evolve, and both in complexity and I think true dedication to the mission to use data to inform resource allocation, decision-making, and improvement.
So can you talk a little bit about quality improvement? I know that I've seen the spreadsheets and the data collection that you have. And then, for example, I know there was a period of time where we were looking at childhood asthma and increasing that. So can you talk a little bit, maybe give an example of how the patient data that you collect helps to inform quality improvement?
So we have a couple of good examples.
Okay, you got that.
Yeah. And we don't work at the patient level data. We don't have access into clinical systems, but on an as needed basis, we can access, and we've done some focus chart audits at a patient level. Again, topic specific and kind of as needed, what's been just a real benefit With the electronic health record, we don't have to go drive to each hospital, get down into the basement in the medical records department, pull 30 charts off the shelf and fill out our paper. We can now sit in our offices here in Montpelier, access, with the appropriate permissions from the hospital's IT department. We get access to the areas of the chart that we need to review, and we can do it electronically now, which is huge in terms of efficiency and productivity. But one thing I just want to add on 9416, we may be back later in the session to talk about a small increase to our bill back. The bill back has never received an increase since its inception in 1994. And it's really time. I would say it's overdue.
How many years is that?
More than
9 years.
Yeah. So.
Every 3 decades, we will.
Yeah, that's what we want to change. So maybe before I dive specifically into the projects.
I don't want to interrupt your flow.
No, very happy, and that we'll get to that for sure. The bill back is capped at 75% of our operating budget, which kind of forces us to go find other revenues, other funding streams, and we've done that very successfully with state partners, as I mentioned before. We are the subcontractor for Vermont Department of Health's Patient Safety Surveillance and Improvement System. That is the serious reportable events, mandated reporting, and we provide technical assistance to the hospitals. We collect and track that data. That is patient level information without patient identifiers. We'll have age, the date of the event happening and so forth, gender, those kinds of things, but not individually identifying information. And we track and report out that information. We have the calendar year 2022 report about to be released. So very important, again, that confidentiality protection is very key. And we support the internal processes of root cause analysis, and corrective action plan is developed for every serious reportable event. That's very integral to our work. And then we work with the State Office of Rural Health, again, to leverage federal funds, state funds to support our smallest hospitals. Those funds are directed to the critical access hospitals, so wherever possible. Improvement projects, we collect data through the Medicare Beneficiary Quality Improvement Program, known as MDQIP, and we track a dashboard of performance and, again, direct resources for improvement there. And we are also working with the State Office of Rural Health on health equity trainings for hospital leadership and hospital staff. We are also continuing to do more advanced health equity trainings with the Health Disparities Grant from the CDC through Department of Health. And then we are just adding a new program. We're in the process of contracting right now with Department of Mental Health on, I have to change my slide because they switched the word on me. I will call it trauma-informed care. It's now known as trauma-responsive care. So, but the point being that it's essential training for folks in the emergency departments who are now assessing and evaluating individuals coming in, and in many cases, spending a great deal of time boarding in the emergency departments, but understanding the principles around treating and evaluating folks who have experienced trauma. So UVM has just completed that training, and Department of Mental Health approached us to right-size it for the mid-size and critical access hospitals, but to disseminate statewide that skill training. And then federal partners, we've just received funding from both senators. Senator Leahy's office, congressionally directed spending of over $900,000 for our Vermont Emergency Telepsychiatry Network. And then almost $500,000 from Senator Sanders for the Vermont Telemedicine Access Project. So we're, again, what we do is kind of the heavy lift to acquire those funding streams. We're in the process of validating the requests for equipment under the Senator Sanders money. And then we'll get that equipment into the hospitals, nursing homes. I was just talking with Laura Losey in the hall. Several of the nursing homes will be getting significant equipment purchases that we do that heavy lift centrally and then distribute as able or as needed. And then we've also been able to leverage private philanthropy through the Vermont Community Foundation and other private funders to provide collaborative assessment and management of suicidality. That training, we trained, and this number needs to be updated. It's now over 300 independent mental health providers. Designated agencies are also receiving this training through the Department of Mental Health and the Suicide Prevention Center. But our project focuses on the independent mental health providers who aren't necessarily connected to an organization where they would pick up that training. And then in response to the pediatric boarding crisis in the emergency departments, we've literally assembled like a production line in our offices, activity kits of card decks, coloring books, pop toys, all reviewed. And this is modeled after the Boston Children's Hospital program that UVM adopted for their children's hospital. And we leveraged for all the emergency departments kits in age groups, and this first age group gets me every time, 3 to 6, 7 to 12, and then 13 to 18, age appropriate activities. And we've had hospital emergency staff, when the bins were delivered to the hospital, tear open the bins, take out a box for the appropriate age group and put it right to work. So we've distributed, I believe it's over 1,300, and now we have a request for another 1,000 kits. So yeah, I mean, I hate.
I'm sorry to hear that.
Yeah, I hate to have to do that work. Sadly, it's necessary, and that's the short-term fix. But I think as we get into the Vermont Emergency Telepsychiatry Network, that work is more a longer term fix. And we continue to look for new practices and potential. So yeah, but we're going back to the Vermont Community Foundation to get funding for another 1,000 kits. Yeah. So as an example, we choose our projects based on data-driven information. This stood out in terms of suicide prevention for the emergency departments. 40%, 44% of decedents have been in an emergency department within the year before death. That's a tremendous opportunity for improvement. So that's why that was targeted. The next slide shows that rate is increasing. So there's some urgency associated with that. But our projects are data-driven, and we attempt to be as timely and responsive as we can possibly be. So we formed up the suicide prevention in the emergency department. This timeline is an example of the tools that we use to implement and track. These are the activities of the project. We asked the hospitals to submit their letter of intent. We did an organizational assessment, and what was fascinating to read the compilation of all the hospital assessments, their self-survey, their self-assessment of where they stand relative to the best practices that are available becomes their work plan. And it is so evident as you read through, it literally tells them, here's where you are, here's where you need to go, and here are the steps in between. So it can become a multi-phase, multi-year improvement project. In addition to the organizational assessments, we meet with the network group to present their QI projects, but also to feed back that data on the organizational assessment. So each hospital has a very good understanding of where they sit in the pack. You know, leader, laggard, mid-pack. And in the case of this project, everyone had a lot of room for improvement, so everyone can grow together. And it's nice to understand you're not alone. We had the same experience with the health equity organizational assessments, where one of the staff we spoke to recently said, we had an awful lot of zeros in that organizational assessment. And I could say, well, don't worry, everybody did. You're in good company. That's why we're doing this. We'll move forward together. So in the face of all those opportunities, the hospital then prioritizes a QI project based on their specific needs. It doesn't have to be cookie cutter approach that everybody does the same thing. They choose the project they need for their culture, their assessment, based on their feedback, and move forward. Everyone shares their progress, networking, shares with the group. We had a subject matter expert that would review their plans and provide feedback throughout the project. Each hospital had access to that. Dr. Edwin Boudreau from the University of Massachusetts, and he was a tremendous asset in this work, to literally bring the subject matter expert into the room to have the conversation, into the room, of course, virtually at that time. But then, updates on their projects, how they did, your final standing, and then a final networking meeting that then, one second, so part of the benefit of this to incentivize the hospitals and make it worth their time, because they have to take folks out of their daily responsibilities to focus on this work. $12,500 stipend for signing on and participating, an additional educational stipend they could take advantage of for $1,500 to attend a conference, additional training, whatever they chose or prioritized. And then we also conducted a focused mock survey specific to the emergency department and specific to suicide prevention care, with a very concentrated focus on ligature risk, but also reviewing policies, procedures, and everything associated with delivery of care in that environment. Of course, the technical assistance from our team and membership in the peer learning community that will outlive the project, so they have those resources available to them, and then access to the subject matter expert and educational programming. Now, so this is not an eye test. This is the tracking tool. This, again, you don't have to read this. This is the tracking tool that we implemented, in our QI project management process, to just keep track of everybody's work throughout all the milestones as designed in the project. And this forms up our final report back to the funders that provided the revenue to conduct the activities. And then here, the outcomes were just phenomenal. Every hospital participated. Every hospital completed the organizational assessment. All hospitals did the QI project proposals. They were all satisfied, and the project networking meetings met their needs. All attendees indicated, as a result of this meeting, I have a better understanding of suicide prevention practices that can be implemented in the ED setting. That was the whole purpose of the program: get everyone to have comfort and confidence with this population in the emergency department setting.
I have a really probably a not relevant, or maybe it's a stupid question, but you're training folks who are in the hospital. Have you had any interest from people outside of the hospital, including public safety, for being engaged in this kind of training?
We would be happy to take this process anywhere it's needed. We started in the emergency department because of just the outstanding need at this time.
Yeah.
ED staff are great at multi-vehicle car accidents, plane crashes, trauma and physical trauma is treated in the emergency department. This is a challenge, so adding this skill set or honing this skill set for that frontline group and anyone who could benefit from this, we would love to take this.
Thinking of EMTs who have a difficult
Yeah.
time with this as well. Okay.
Yes,
I don't, we probably should keep going because we did start behind, so we're gonna finish behind, but we're gonna get there.
I'll keep going. And everyone, progressed in their QI projects. I think in one or two cases, they set a target of 100% staff trained and weren't quite able to reach the 100%, but made it to 85%. And again, over 200 staff were trained in what's called CALM, and that's counseling on access to lethal means. That is a key component of assessing and managing suicidality and understanding the individual's risk, and then moving forward with a safety plan. So just having so many folks trained in that skill set was very significant. And then all hospitals made improvements to their suicide care policies and procedures. And this was all based on during the public health emergency and our telehealth office hour series. We had a presentation from Dr. Sai Saeed from North Carolina, and it's called the North Carolina STEP program. And this is what our Vermont Emergency Telepsychiatry Network, our proposals and the project that we're putting forward. We have based it on the North Carolina program because their results include cumulative cost savings of over $39 million, overturning 40% of involuntary commitments, and then over 1,200 patients avoiding unnecessary hospitalizations. So we have great hopes that implementing a statewide telepsychiatry network here in Vermont would help to produce hopefully similar, maybe not quite this significant as we come out of the gate. But in the first week of this month, Rutland Regional Medical Center started their pilot demonstration project with the Brattleboro Retreat for pediatric and adolescent telepsychiatry. So we're out of the gate on that project and hoping to make an impact with those pediatric cases, as you had mentioned it and suggested. We are selecting a critical access hospital as the second demonstration project. And so far, our progress to date, in addition to the Rutland program being live, we've had the advisory board meet one time, and then we'll look to expand this from the 2 pilot demonstration currently to a statewide network. And we would probably come back to the legislature to look for funding to support that expansion. This funding that supports currently the current demonstration projects will end, I believe I can't remember if it's September or November, I think it's September.
So your request would be next year.
To continue this to a 3 to 5 year project expansion, and then be able to roll this out statewide. And just as a takeaway, our organization is a resource to the Senate Health and Welfare Committee. If you need information on clinical best practices, quality improvement, please don't hesitate to reach out. We focus on coordination and alignment of our projects anywhere we can. We don't want to duplicate. We want to leverage what's out there and align. Of course, reducing burden for hospitals and other project recipients. Again, we kind of shoulder the heavy load and pass out the money and support that internal process. And we are very focused on disseminating best practice through the process.
Thank you. If it's a short question,
It is
Go
a
ahead.
really short question. It might be more for you, but we integrated you into our Act 167 work,
Yeah.
right?
yep.
PQH, not you first specifically.
So hold that thought. Then
Yeah,
we'll come back to 167 and maybe you are integrated in with 167. That's the question. Are you?
Yes, I'm
Some
trying to
of the
think of all the touch points.
The quality improvement and data stuff that we put in there, I think.
Yeah.
I think that was my recollection, but
The telehealth analysis.
Yes.
Audio only.
You're all in.
Yep.
You're all in,
okay, cool.
which is a good thing.
Yeah,
That is why we put them in.
As you were talking, I was like, wait, I
Yeah. DPQHC has been always one of my pets. I'm so glad that, it's thriving.
Yay, thank you.
Thank you. Thank you
Again,
for your work. It's all behind the scenes. Nobody sees it, but it's very much appreciated and wanted you to know that.
Yeah, thank you. Thank you so
And
much.
share that with the folks that you work.
Absolutely pleased to.
Thank you.
Thank you again.
All right, and you'll be back, I'm sure. I've got lots of questions for you. I'm sure everybody else does.
I have to step out for a few minutes. I will be back. I already told Rachel that. I'll
Okay,
be back though. Excuse me.
all right. Rachel, welcome.
Thank you.
Thank you for being here.
Thank you for having me.
You should take that down, Alex.
Yeah.
How to do that. I think it's on your computer.
Oh.
You're gonna leave it. He can do it. He can do it. Are you gonna share?
No, I'm just gonna talk, but this
That's
way I have
good.
a couple notes. I just like
Okay.
to talk to folks.
But first, do you know everyone around the
I
table?
don't think I do know.
So we're gonna do that
So it's
again.
just
You
an
know
introduction. I
Senator
Senator
Hardy.
Hardy.
So we'll start with Senator Williams over here.
Terry Williams from Rutland.
Okay. Nice to meet you, Senator.
It's representing Rutland County, come from Proctor.
Oh, okay.
Martina Rocky, representing Chittenden Central, and I live in Burlington.
Yes, and so I'm surrounded by Rutland.
Yes, you're surrounded by Rutland.
Good or bad?
Yeah,
It's all good. Okay, so thank you for being here. And we did hear from our healthcare advocate,
Yes, and I brought him back
part of the
today.
shop. And, so why don't you introduce yourself and your organization? And we'll spend a bit of time when Commissioner Levine comes in. We'll get to a closing.
Okay. Sounds good. Well, so for the record, I'm Rachel Seelig, and I am here with kind of two hats on today. I'm both director of our Disability Law Project, which provides legal services to people with disabilities where their legal problems are arising because of their disability. I'm also our staff attorney for government relations. So like Mike, I'm here in the building a lot. And if you have constituents who are in need of assistance from Vermont Legal Aid, I'm someone that you can reach out to and speak to. And we'll try and connect that constituent with the right part of legal aid. I'm also I'm low tech, but I will send this to Alex as well. I have just a description of the 11 different projects that we now have at Vermont Legal Aid and the contact information for each of their directors. But again, find me, find Mike. You don't have to worry about which part of legal aid might be able to assist one of your constituents. Yes,
With that in mind, can I speak with both of you offline briefly?
absolutely.
Thank you.
Yes. I think one of the things I wanted to do this morning was just talk about what we do at Legal Aid and how we can be helpful. And then I'd love to kind of touch on a couple of the different policy issues that we're hoping to work with your committee on this year. So as I said, we now have 11 different projects. There's often a perception that we only serve very low income people, and I want to disabuse you of that notion. We do have a couple of projects that are income limited, but many of our projects can serve Vermonters regardless of income, as long as they meet other grant funding requirements. Mike's project is certainly an example of that. He can work with any Vermonter who has a healthcare need. My project is an example of that. Any person with a disability, we're going to connect them to legal assistance if that is a legal problem connected to their disability. We work with folks on housing issues, benefits issues. We work with folks on civil rights issues. We work with folks on access to unemployment. You know, we're really very broad scope of work that we do. And so if you think someone may have a legal issue that Legal Aid could help with, err on the side of asking us, because we will be able to answer that question for you pretty quickly. So in terms of policy work that we're hoping to work with you on this year, this is why I brought the little device, so I don't forget the important areas I want to talk about. The first is homelessness, and I'm sure you've already been hearing a lot about homelessness, especially as we're working on budget adjustment and then moving into the next year. And this connects to housing, which I know is not your territory, but these two things really can't be completely disconnected. So there are a couple of different things that we're hoping for. One is to continue funding and continue policies with general and emergency assistance to keep people housed while we work with the housing developers to build more affordable housing. The negative health effects of homelessness, the cost to our Medicaid program, the cost to our schools and our education programs of homelessness are tremendous. And so when we can keep people housed, that's a really good investment of funds. So that is one thing that we'd love to work on is finding ways to keep as many people housed who are currently homeless as possible. The second is Reach Up, and I will admit I am not the Reach Up expert at Vermont Legal Aid, but I'm happy to bring Olivia, who is our Reach Up person, in to talk to you about things I don't fully understand, like getting rid of the rateable reduction over time and making sure that the allowances are actually connected to reality. I believe the housing allowance right now is like $400. There's nowhere that you are renting for $400.
Rent something. I don't know what.
Maybe a box.
Yeah.
I mean, so that's something that we would love to talk with you about more. For my project, it really is the Medicaid home and community-based services workforce crisis. We do a lot of work with people with intellectual and developmental disabilities who have not had the staffing or the housing supports that they needed for over 2 years now. We had one client who lost his housing with 2 days' notice. His elderly mom, who lives 2 states away, had to drive here to pick him up and bring him home and try and provide 24-hour care for him and her husband going through cancer treatment because we were not able, as a state, to provide him the care that he had been promised. We have another client who only speaks through augmented communication types. He has not had anyone who can support him in typing for more than 2 years. He's had no services. His mom had to give up her job to stay home and take care of him 24/7.
So how much of that is related to COVID and the,
There was
social
already a
distancing?
workforce shortage before COVID.
yeah,
COVID made it much worse. The vacancy rate is now hovering around 26%. The turnover rate is now up to 33% a year. So these people are also, even if they have staff, they're losing those staff so quickly that they aren't developing relationships. These people aren't, being able to like really understand what their needs are and how to make sure they're supported in employment, in accessing the community, and being safe in their housing. We think this is really an area where your oversight is needed. That the level of urgency that this problem represents is not being met with by Dale in terms of what the state is doing to meet this problem. And we know it's a complex problem. We know that workforce is not just about wages. It's not just about housing or transportation. It's about all of these things. But we're not seeing solutions coming out of the agency at the rate that they're needed to get people back to a place where they're safe in our community. And we're very concerned it's going to lead to out-of-state placement and institutionalization of people who do not need institutionalization if our system is working the way that it's meant to. So that's, I think you know for sure Barb Prine, and I'm happy to bring her back in and she can talk about some more of her client stories. Next thing I want to talk about briefly, again, this intersection of human services and housing is the global commitment waiver that was approved in July included funding for a supportive housing pilot that's not anticipated to start for a couple more years. And we would love to see your committee take that up and hear from the state about what they're doing so far, because those supportive pre-tenancy supports, tenancy sustaining services, and community transition services, I think are a real key in helping people once they find housing and they have a disability retain that housing. And so getting that pilot, which I think is not really intended to be a pilot, but is intended to be permanent, up and running, or getting some of the mapping of the available services while we're waiting for it to get up and running is a pretty urgent need, and I think connects to the homelessness piece and the housing piece that you're all hearing a lot about. And then the last thing I'm gonna do is plug Legal Aid. We love the work that we do. We are doing our call volume is twice as much as it was before the pandemic. We were getting about 13,000 calls from Vermonters a year in FY18. We're getting about 26,000 a year last year and the year before, and we're on track for about that many this year. At the same time, we have not seen an increase in our AHS budget to meet that need. We had an increase last year. It was completely eaten up by inflation. And so in order to keep doing the work that we're doing, to stop losing staff, we've shrunk our 3 core programs, our poverty law, disability law, and elderly law projects by about 8.5 full-time equivalent staff over the last 5 years. To stop that, to be able to keep serving Vermonters, we are looking for a pretty significant increase of about $1.3 million in our base appropriation. And so we're hoping that we can work with you to get support for that with the Appropriations Committee when the budget comes along. We did a study in 2019 before the pandemic that every dollar we invest in Vermont Legal Aid and free legal services is about an $11 benefit to the state of Vermont. So we think we're a good investment in addition to the services that we provide. We help the state overall. So those are the big topics of policy that we want to be talking with you about. And I think we have a couple minutes for me to pause and answer questions about legal aid and about the policy.
Yeah, that's terrific. Yeah, thank you. This is great. And I know that each one of us at one time or another has or will come to legal aid
Please
with
do.
a question
Yes.
and a constituent. And just maybe talk a little bit about if someone came to with you, your organization, with a question about Medicaid eligibility.
Sure.
And then what's involved with those almost 30,000 people?
Yeah.
Because each person is coming in with a different question. How do you work with folks?
Yeah, so I'm gonna let Mike answer that question
Perfect.
because it's right up his alley.
Good.
So one thing that's a little bit different about the Healthcare Advocates Office than the rest of legal aid is that we're set up as a helpline. And so we have a little bit more of a sense of immediacy in our response. We do get calls from people who are like, I've got a procedure scheduled for tomorrow, something is amiss with my payment, like do I need to cancel it? We do get urgent access to care calls, and so we have a within 24-hour or that day response. Senator Lyons, your question, was it Nolan who tried to make the joke earlier that if you've seen one Medicaid program, you've seen one Medicaid program?
Yeah.
There's a lot of people think of Medicaid as like, Medicaid for children and adults, sort of that's the one that's talked about, but there's a lot of details depending on what Medicaid program you're in. And so having people who address those details every day makes them sort of ready to respond to sort of knowing the details, knowing how to respond.
But the constituent will talk to one of Mike's eight advocates who are experts on Medicaid, on Medicare, on private health insurance. And one of the things that's great about them is that even if somebody's calling because they think, oh, I should be eligible for Medicaid, I heard, because I'm low income, and they're a little bit over that income limit, but maybe they're a person who's with a disability who's working, the whole other income limit there. And so they can explore like, what is the way that we can get you eligible for Medicaid, rather than just like, was this decision that you're not eligible right or wrong? So they really do.
It does take time.
It takes time.
Takes a lot of time.
Yeah, helping educate people about what the rules are
Yes.
so that they can figure out what the right course of action is.
Right, and having read the rules, And I got another set over here.
Yeah,
Yeah, that
they're
pretty
complex.
extensive. Yeah.
They're very complex.
Yeah.
And, we haven't had people coming off of Medicaid through the pandemic. And that's about to end, starting at the beginning of
Oh,
April.
and the redetermination is coming up.
redetermination
You're
is
gonna be
coming up.
extremely busy with that.
So, we are working on being as ready as we can to help people figure out those transitions.
Just to put that in scale, people often talk about the maybe 30,000 Vermonters who are on Medicaid who might not be after redetermination. That's the wrong number. That is an important number to focus on, but there's over 200,000 Vermonters on a program, on a Medicaid program that haven't lived through redetermination in 3 years. So that's a big chunk of work for Medicaid and for us to respond to Vermonters who are trying to figure out how to manage.
Actually, and this is a question I probably should have asked Diva, but is there a timeline for that? What is it?
It's gonna be over the next year.
So it is a whole year.
14 months, yeah. But it will start in April.
Right.
So they will first work through the people who they know are no longer eligible, they've aged out, or they've reported that their income is over. That's gonna be the first chunk of work, and then they're gonna split everybody else out over the next 14 months to do what used to be a regular redetermination process.
Good news is we'll be out of session for a lot of that time.
And you're gonna
We'll be busy.
Any questions for Rachel?
I have a question, but it'll be
Yeah, okay, all right, so we're good. That was great.
We like to be short and quick. I do have another little handout that I'll share with you, which is
Please.
about our budget. That kind of gives you a little
I knew you
visual.
would do that.
I know.
Thank you.
Gives you a little bit of a visual. And yeah, you can take that one and I'll leave one for some other areas. Of the increase in calls, and I didn't mention this, but the calls are also much more complicated than they used to be. So we spend about 3 times more time just getting people in the door, and helping them understand their problem and giving them that initial advice, than we had to before the pandemic.
Yeah, and if I could just, our intake system is seriously strained. It is not sustainable for us to continue to manage the volume that's coming in and be able to provide help to people who really need help.
Yeah.
So
Right
it's
now,
kind of urgent.
unless somebody has like, I've been locked out, my utilities are shut off, we call those folks back right away, kind of like with Mike's program and the like, I have surgery tomorrow calls. Other people, it's taking us 7 to 10 days to call them back. It's too long. We don't like it. Without more people, we can't reduce it. And so that's one of the pieces of our ask is 3 more full-time equivalent folks to be able to respond to those calls and increase that capacity. So,
Thank you.
yeah.
what's that gonna include, for infrastructure changes? If you add more people, you're gonna be able to have the, in your offices?
Yeah, we have room in our offices, so we have 5 offices across the state. We have room in our Rutland, Springfield, St. Johnsbury offices right now, and we're working on expanding our Burlington office to have more space there. That building is currently at capacity, but there's a little bit more room in it that we can take over that's been leased to someone else that'll give us some more space there.
Can folks work from home, work remotely?
We do have folks working remotely as well, and so in fact, everybody has a work from home, work in person plan, so that we can have offices shared on the days that the other person isn't there. So we're doing all of those things to maximize the use of our space.
Thank you. I know that I'm gonna hear this again.
Yes, we'll be back as
And-
often
and
as you'll let
just-
us,
just-
as always.
Just to let you know, I mean, we are not the appropriations
I know.
committee, but as we listen to folks and we see what the issues are, and we have bills up on the wall that
Yes.
have appropriations, not that one, but
Not that one,
other ones, but have appropriations requests, and ultimately we'll look at the budget And then we'll look at what we have and what we're wanting to do and pass to the full Senate.
Yeah.
And then we make an ordered sort of list.
Priority list, yes, yeah,
So, and that will, we'll send it down
yeah.
to approach. We approved the system last year and made a whole new way of doing it, so
Good.
we'll see how this goes. But if you have your handouts that we can. put
I
on
will
the
email them
webpage,
to Alex,
That'd
absolutely.
be super.
The one that has all of our project directors' contact numbers on it, we'd rather not have that posted on the
Okay,
website,
that's
but we
fine.
do want you all to have it.
So we have it, but this is, so that's good to
Yeah.
know.
If you email me that one, I can email that as a digital copy to the committee
Perfect.
members,
Yeah.
and then I'll just post the other one.
I will do that as soon as we're out of here.
No
Okay.
worries, thank you.
All right.
Thank you.
Thank you so much
This
for your
is
time.
terrific.
We look forward to spending more time with you.
Oh, yes, I'm sure you will, and I know we'll be seeing you around the building.
Oh, yes, absolutely. And again, please come find us if you've got constituents.
So we're gonna go off line